Rahim. Good morning. बल्कि अब तो afternoon होने वाली है, तो good afternoon, everybody. It was great listening to Dr. Aisha, followed by Professor Rashid, and I must thank Pakistan Academy of Family Physicians for giving me this opportunity to come, stand before you, and share my 2 cents of what I have learned in my institution. So, Children's Hospital Lahore, I'm proud of it. It's been 14 years in different capacities. I've been serving this institution, and pediatric pulmonology is very close to my heart since I'm working in that unit, and we have the largest unit when it comes to managing and catering the outdoor patients with a pediatric asthma clinic that is dedicated on the Fridays. So if you have any sort of complicated cases when it comes to pediatrics, you can always refer to us. So, my topic is a bit grave in the sense that you are there in your circumstances, in your clinics, managing cases that are coming up. But what if someone comes in an extremis? Then what to do? And particularly if that certain person is a pediatric age group, then how to go about it? In pediatrics, we have to be very specific. So that's why I'll be sharing a few guidelines and then certain experience nuggets as well. So learning objectives will be very sleek. When a patient comes to you in extremis, when to manage that case in a pediatric emergency setting and how to manage, of course. So one fine day you get up, go to the children's hospital in the emergency, and a similar sight you see over there, overcrowded, particularly in this season, because we're getting so many respiratory-based complaints. Over 90% of the indoors, emergencies, and outdoors are due to the respiratory complaints. So let me start with a very basic scenario, a very typical scenario. An 8-year-old girl was slightly obese and was a known case of intermittent asthma. She presented with fever, cough, and difficulty in the breathing. So immediately she was referred to the emergency. The girl's father reports that she required multiple puffs of salbutamol meter dose inhalers during the day and overnight, but there was no improvement. Due to the use of bronchodilators, there was an initial improvement, but in the morning, she again became short of breath and can speak only in shorted sentences, a very typical scenario of acute exacerbation. Her history was significant for prior asthma hospitalizations, but thankfully there were no ICU admissions. She was using salbutamol on SOS basis. Her primary care physician, who happened to be a family physician just like you, advised to use inhaled corticosteroid for daily use 4 months ago. But the prescription ran out, and the father continued with the salbutamol, but never refilled the inhaled corticosteroid. So when we examined her, she was febrile, was tachypnic, with accessory muscle involvement, and there was inspiratory as well as expiratory wheezing. Bilaterally reduced air entry throughout the fields, and her oxygen saturation, when checked from a pulse ox, was about 88%. So these were the differentials that should pop up in your mind. Infections being the top differential, could be an exacerbation, or maybe it is some sort of a post-flu phenomenon of irritation as bronchitis. So immediately certain questions should come in your mind. What are we dealing with right now? What exactly is the underlying diagnosis, then what is the severity of the diagnosis? And then definitely you need to advise the patient on how to manage it, both in the setting, in the hospital, as well as when they will go home. So how to go about it? This is all what we know. So a quick review of what is already known. These are the symptoms from the least severe to the most severe. And if there is a respiratory distress coupled with wheezing or cough in a pediatric patient, then patient should be considered to be managed in the emergency. Whatever the presenting complaints are, sometimes the history is not given and your clinical exuberance comes up and you pick up signs. So you have to differentiate between signs of distress and signs of non-distress to triage the patient in the form of, number one, maybe a case with extremis to be managed in the emergency, or a case to be managed in the outdoor basis. So how to do that? If these are the symptoms, then you should think of referring the case to the emergency or managing the case in the emergency department. When it comes to dealing with a pediatric patient, these are the top differentials that should be in your mind, specifically in the local causes. By local, we mean respiratory causes. And these top 5 are the most common differentials that we always consider, whether the child is a known case or a new case who come up to us, and before advising, we do consider these. And there are certain systemic causes as well that mimic childhood asthma. So from the most common to the least common, these are the top 4 that we usually take into account in a pediatric patient. So with this knowledge, the case scenario is summarized. Again, you go back to the scenario and you say that, okay, it might be a case of acute exacerbation. And then you ask these questions. There was no pertinent history reported about these, but there was use of cough syrups as well as NSAIDs, which are known to be triggers of the asthma in a pediatric patient. So these were the differentials you came up with. Since you were sitting in an emergency, you ordered a chest X-ray. These are the findings which show hyperinflation and slightly tubular heart. A typical tubular heart might not be there in a case who is of pediatric age group. And you make a diagnosis. Now, how to manage it? So, we're going to quickly go through the different steps of management, and then we're going to discuss a few guidelines with you. So, in an emergency, you give oxygen inhalation, you maintain an IV line, you do the ABCs, check for the vital signs, then oxygen saturation and inhalation you keep on monitoring, and then you plan for the management plan. What is that? You check for the severity of the disease, monitor for the response of the intervention, which is very important, and then you go through a certain algorithmic approach which has been prescribed in different guidelines. So, symptom severity, this is all there in the literature, anybody can look it up. But what our scenario had, out of these, was it mild to moderate or was it severe? These were the 3 pointers in our scenario which labeled these symptoms as severe. So, we have a severe symptomatology. Definitely we will manage it in the ER. So this was the first holistic assessment focused on the respiratory system that we did. Slightly tachypnic for age, wheezing, both inspiratory and expiratory, air entry was reduced all over. She was oriented, and venous blood gases were slightly on the hypercapnic. This was the CO2. So, there have been a certain changes when it comes to managing a case, particularly a pediatric case. Certain things have moved up in the first hour of the management. Certain things have gone down in the second or the third hour. So these are the latest 2024 guidelines. Oxygen inhalation is the first. In the first hour, steroids are mandated to be given. And you can choose between IV, single shot, oral, or inhaled corticosteroid. Whatever is your choice, it should be given in a stat dose, right in the first hour. Because what asthma is, it's actually chronic inflammation. And then definitely you need to bronchodilate. So, either you give it 3 times or you can give a continuous nebulization. In a pediatric population, it is safe if you give 3 spaced nebulizations. And then at the end of the first hour, if the response is not adequate, you can consider addition of magnesium sulfate. So first hour is through. Now, when I was a house officer back in 2007 and 8 in Mayo Hospital, Lahore, I used to remember that we used to have like drop form of Ventolin solution, and we needed to calculate and dilute that. Okay, 1 milligram I've taken this, I dilute it in the 4 to 5 gram, I make it 5 ml, so 1 ml will contain 1 milligram of Ventolin. But now, guidelines and evidence advocate unit dose vials because they are pre-diluted, they are safe, and they are secure, and they are sterile as well. So how these differ, how these change the convenience of management in a pediatric patient who is managed in the emergency, these are certain salient features. We'll quickly go through those. Sterile and precise measurement, and a newbie can also come up and give the desired dose. It is time saving. You take it out, put it in the nebulizer solution, and then statly nebulize it. There is a reduced contamination risk because it's a monodose vial. Once given, the vial is empty, and then for the next nebulization, you need another dose. You need another vial. And then all the ERs have adopted these monodose guidelines or the unit dose vials unanimously. So it's high time that we also advocate those. So this is the graphic representation. Important is that when you twist, you can take it off, put it all the way around, and seal it if you want to reuse it. So this maintains the sterility of the solution. Then again, prevention from external contaminants, enhance medicinal integrity, cost effectiveness, because unit dose vial contains 1 unit, and if it gets wasted, probably there is no monetary loss over there. And then improve safety as well, lesser chances of spillage, lesser chances of biohazard. So coming back to our scenario, after the first hour, there was slight improvement in the parameters. For the sake of time, I have highlighted only the improved portions. So then what to do? We're going to go to the second hour. In the second hour, we continue with the oxygen inhalation. And now we're going to combine short-acting beta agonist along with anticholinergics, and we're going to again give 3 cycles, 15 minutes apart. And the dose of ipratropium bromide is given over here. It is also available in the unit dose, followed by beclomethasone dipropionate. So steroid is also given in the second hour as well. And at the end of the second hour, if the child does not improve, you have an option of giving subcutaneous terbutaline. It is a slow dose, it is a slow release, and you can repeat it after 15 minutes of interval. So after completing the second hour, you do a third evaluation. Markedly improved. only the tachypnea is still there. In the third hour, you would continue the oxygen inhalation, and MEG sulfate should be given 3 times. Whenever you're giving magnesium sulfate, you need a cardiac monitor for that, because there is a risk for arrhythmias. After that, first you should give a bolus dose and then continue with that. And after MEG sulfate, you have the option of intramuscular or subcutaneous adrenaline. Specifically, if a pediatric case goes to the third hour, you should consider the systemic causes and should consider anaphylactic shock. That's why it is advocated adrenaline for anaphylactic shock that mimics acute exacerbation. And then IV terbutaline. Usually in children's hospital, this is the most favorite drug of the postgraduate residents, and they start it right from the start and do that. Time and again, we educate them, but this should be reserved if you follow all the steps to the third hour. And this is the assessment after the third hour. Markedly improve, everything is okay. Now you plan for either discharging the case or shifting the case to an ER. It is advocated for the sake of safety that you should not discharge from the ER directly. You should admit the case, maybe for a couple of days or so, and then maybe shift the patient out, or maybe discharge the patient and bring them back to your follower. So this sums up my presentation. I would like to sum up in 30 seconds what the GINA guidelines of 2024 report. Number 1, there is no use of salbutamol alone, whether in extremis or in the continuation phase. It should always be combined with an inhaled corticosteroid. Number 1. When it comes to steroids, high dose of inhaled corticosteroid in the first hour are recommended with a very strong evidence, and it also reduces the hospitalization admission and subsequent use of corticosteroids, and reduces the death and the hospitalization burden. Wherever possible, you should give systemic steroids. If the child is unable to take orally, give IV. Otherwise, oral is as good as IV. So it's your decision. Follow-up of children should be from anywhere between 3 days to 5 days. And follow-up plan in the OPD should be after 1 to 2 days in children. And if the patient is a bit of a greater age, you can go for 5-day follow. So with this, I conclude, and if you have, these are the references. And if you have any questions, I'm glad to answer. Sorry?